Dr. Stanley Paris, welcome.
Thank you.
I am in your American hometown.
Oldest city in the United States.
Oldest city in the United States. No one believes me when I tell them that. And I'm a big advocate of St. Augustine. Why is it the oldest city? What happened here?
Oh, I don't know. The Spanish came and they settled it. Of course, the people in New England, the Pilgrims, they think they were first. Mm-hmm. And because this time Florida was not part of the United States. Mm-hmm. And so, in a sense, New England was first. But when Florida became incorporated into the United States, there had been a settlement. The most continuously occupied settlement was here in St. Augustine. So that became the oldest city in the United States then.
And how did, an individual from New Zealand end up in St. Augustine? And why did you stay here in St. Augustine?
Well, I had come to America in 1961 on a scholarship from the New Zealand Workers' Compensation Board to study spinal treatments. I returned to New Zealand, but I could see the future of education would be at the academic level. We were being trained in hospitals in those days, and we got a diploma, but I could see that we would be moving to degrees. So I thought coming back to America, which I did in 1966, to earn a PhD would place me as the first New Zealander with a PhD in physical therapy, would place me in a leadership role, and I could influence the future of the profession, which I thought needed changing. So that's why I came to get a PhD. I had a faculty appointment to Boston University and a clinical appointment at Massachusetts General Hospital.
And was the intention always to go back to New Zealand for you?
It was. But my plans to get the PhD, like many, didn't work out. I left the university within a very short period of time because the studies I wanted to do, they would not permit me to do. They wanted me to study osteoporosis in rats for several years. I wanted to study biomechanics and anatomy of the spine, which I thought we had agreed on. So, we just terminated the relationship amicably.
Was there a reason why they were not
it was grant
on
money.
board? Mm.
And also there was a change in attitude. The Department of Anatomy had changed its name to the Department of Cell Biology, meaning that we've moved beyond anatomy. Anatomy's finished. There's nothing more to study. We now go into cell biology. And our grant money is in osteoporosis. So you'll be feeding rats the first year and studying rats for years. And when you publish this number of papers and this sort of thing, in about 5 years, you'll have earned your PhD. But, osteoporosis is important to physical therapy, but, reading one paper on that would be enough for me, not to spend my life doing that. And so if you're not getting a PhD in something that moves you ahead with your knowledge, if it isn't to your liking and to the advantage of you and your patients, it's a waste of time. So I left, went into private practice and built clinics and things like that and started teaching continuing professional education in my area of expertise, which was manual and manipulative therapy.
In New Zealand, where did you grow up?
In Dunedin. It's in the South Island of New Zealand. Pretty cold, damp place. But it was the center of the gold mining activities in the 1840s and 60s. And as a result, it had a lot of money, and it spent it on building great schools and universities. And so the University of Otago, from which I have an honorary Doctor of Laws, is a prestigious research university in New Zealand. And that's where it all began. The medical school, the dental school, the physical therapy school, they all started there in that town. Now there's a second dental school and 3 physical therapy schools. Population's increased, of course.
And you, Stanley the boy, how did he grow up? What was his interest?
Well, his father was a physiotherapist. Actually, my father was a veteran of the First World War, and he came back believing he'd go blind because he had suffered some war injuries to the head. So he tried a few jobs, like one piano tuning, and found he couldn't do that. And then they opened the School of Massage and Medical Electricity. And he thought, I can do that, even if I go blind. So he took that on and qualified. It was only a 6-month course, but over time that evolved into the School of Physiotherapy. And physiotherapy is synonymous with physical therapy today. And it's a degree-granting program down there now.
What is it, by the way, because something I wanted to ask you about, the difference, the semantics of the physio versus physical.
Oh, there's no difference in practice, really. the difference will exist between one country and another. But when we founded the World Confederation of Physical Therapy, one of the first president happened to be an American, but just 2 or 3 years ago they changed the name to World Physiotherapy. So those two names are pretty synonymous.
Yeah, but was there a practical difference?
No,
Okay.
not really. Oh, but
Yep.
yes, there might be between one country and another, because between one school and another, up to the expertise of the faculty. But there wasn't a great difference between, say, English physiotherapy and American physical therapy. And New Zealand followed the English model, that we sent our faculty over to get trained there to come back and teach. I never took that training because I thought that was a waste of time, learning to teach the same old thing. I wanted to get a PhD.
So you saw your dad join this school of massage and what is it, electrical...
Medical electricity.
Medical electricity.
Or electricity.
Yeah. And that evolved into what it evolved to.
Physiotherapy.
And you saw him evolve within that. Did he also evolve as a practitioner?
Yes, he did. He had a very busy practice, but he got interested in manual and manipulative therapy, and he bought some books on it. And manipulating the spine, if you're never been trained in it, would be a kind of scary and risky thing to do. So while he was interested in it, he never tried it, because he had a successful practice. He didn't want to take any risks. Everything was going fine. He didn't need to do it. But I accidentally, as a student in my second year, I accidentally manipulated a patient. I had a class of back pain patients. Under socialized medicine in New Zealand, individual care is not all that common. In those days, you had a bad knee, you were in a knee class. You had a bad back, you were in a back class. And you were treated by students at the school, and faculty were overseeing you. And I had a back class, and one of the exercises was lying on your back and get your right leg over your left leg. And this gentleman was having trouble doing it. And without thinking, I reached over and picked up his leg, held his shoulder down like it's supposed to be, pulled his leg across. And it was one of those moments where there was no other noise in the world. His back cracked on the wooden floor. Everyone could hear it. I paralyzed, he paralyzed. And I stood back, and the instructor came over, disciplined me, dismissed the class. It was on a Friday. I worried all weekend what I'd done to this guy and what was the protocol for going to the hospital on Monday and apologizing to him, because I'm sure he'd be in hospital. So Monday the class reassembled, and he wasn't there. So I was all in sweats when suddenly he walks and runs up to me, shakes my hand for fixing his back. And it's one of those occasional, but they're not unknown, events that can happen with manipulation. I go home and say, now I tell my father what happened and how I spent the weekend. And he said, well, you manipulated him. And I said, am I going to learn that? He said, no, they don't teach that. That's chiropractic. And I said, well, maybe I need to be a chiropractor. And he says, no, here's my books. Take a look at this. And if you want to study this, I'll help support you, go overseas and study from people like Dr. Suriaks at St. Thomas's Hospital and a number of other people, physiotherapists and chiropractors and osteopaths, and then come back. So I made that my ambition. The day I graduated from school, I opened a back clinic at the hospital. Nobody wanted to treat backs. I did. I happened to treat the chairman of the hospital board, fixed his back with a Suriaks maneuver, which I'd self-taught. And I got a grant from him that introduced me to the authorities around the world. And I traveled overseas for 2 years and studied the spine.
But you still, before that experience, there was still, something that led you into that classroom and into your field of studies. Was it because of being exposed to your father's profession?
Oh, I think so, yes. In those days, you went straight from high school into your profession. Yep. You went straight into medical school or dental school or mining or engineering or law or nursing. There was no pre-med. There was no 1 or 2 years, as they have in New Zealand now, of medical sciences before you make a choice. So I didn't know what to do at the age of 17, 18. I got through school a wee bit faster than most, largely because during the polio epidemic, I was homeschooled for 2 years. And my auntie gave me 3 years of education in a 2-year period. So I come back, I'm the youngest person in my class. So I'm now leaving high school, and I had to make a decision. I didn't know what I wanted to do, but there was my father. He had his office, they call them rooms, on the front of the house. So I knew what he did. I saw us every day. He's taking my cup of tea when I came home from school each day. So I thought, well, he's living well. We're living well. We got a nice house. Mum doesn't work. She has help in the home. We've got a second house at the beach. This is not too bad a life. So that's why I went into physiotherapy. I wasn't particularly inspired until that incident. And then I had a purpose, and I pursued it ever since.
Was there a dream, another dream? You said you were a swimmer.
Well, I've always been interested in athletics. I would say I'm not terribly competitive, but I like to succeed. I like to get on the team. I like to do things that are particularly of an endurance bent. I followed endurance sports, and that's what I am. I'm not a follower of professional sports. I might watch the Super Bowl and the last 2 games of the World Series, but I don't really care too much for professional sports.
The All Blacks?
Well, the All Blacks, of course, now are all professional.
Yeah.
But I swam for New Zealand universities and a tour of Australia. We were all amateur. And even when I was on the New Zealand Olympic team to Rome in 1960, and now you're wondering what sport. No, I was appointed as a physiotherapist to the team. We all got $1 a day, the athletes as well as me. When I was at the Mexico Olympics 8 years later, again as a physiotherapist, now people were being paid and professional tennis players were taking part. And that was kind of the last mixed Olympics. Rome was the last amateur Olympics, where people chose sports to what they were good at. Now, by 1968, they were choosing sports that they'd get more paid in. Because an athlete's an athlete. They can often turn their talent from one field to another because they got that ability. They're super motivated, super physiques and so on. So they got this gift, and with the energy, they can choose. They'll choose the one that gives the most money quite often, unfortunately, for sport.
So what is it about endurance sports for you that you follow and participate? Because you've done some enduring things.
Right. When I graduated from high school, I got the sports award. I was sitting next to the Ducks who got the academic award. He got it in 4 languages taught by New Zealanders. I thought, that's not an education. I had physics, history, chemistry, geography, and English, and I thought I was better educated than him. But I was there for the sports award because I'd won the shooting and I'd taken part in the boxing, and I was the swimming champion, and I played rugby on the second team and things like that. But what I found is that I wasn't particularly strong. I wasn't particularly fast, but I had endurance. So towards the end of the rugby game, that's when I put in my effort because I still had the speed, the endurance. And so my swimming events, I used to win the longer races. Mm-hmm. And when I got to the age of 12 and I was allowed to do a 3-mile race, I won it. So I found out that I had a unique advantage in endurance sports.
Did you think it was something biological or mental?
Oh, I think it's half of it's at least biological, genetic. The other is what your interest is in, Seems like running 100 meters in 10 seconds is not much fun. It's too short. But swimming in a race where there's strategy in it, where you might mislead the other swimmers into what your ability is or stretch them out. Like in a 10,000 meter race, it's all strategy, far more than, it's not about getting over that line in the fastest time. It's getting over that line first or into a place because you outwitted or outskilled your competitors. It can be fun, like a yacht race.
And I'm cycling as well in that same realm, and I think it's also something that like even people that myself that don't follow like long running races
right.
or yacht races
right.
or even cycling
right.
don't understand and don't even see.
Yeah, well, cycling's an embarrassment to me.
Why?
Well, I took part in the World Championship Ironman Triathlon in Hawaii.
Yeah.
And
so is that the one where every day is on a different island?
Oh no, it's all run in one stretch.
Okay.
From 10 to 14 hours or whatever.
So it's one. Okay. One.
Yeah,
go.
you do a 2.2 mile swim, I think it is, then 112 miles on the bike, and then a full length 26.2 mile marathon. And there was 1,200 athletes in the event. I came out 33rd in the swim, which is pretty good, in part because I was able to draft a person who was about 6'3" and broad-shouldered. I got in behind him and drafted him. You can do that. You can't draft in the bike event. They catch you more than 3 seconds, I think it is, behind another cyclist. They disqualify you. Mm. So anyhow, I drafted and came in 33rd. But at the end of that, I was about 1100th at the end of the bike race, 112 miles. And then started the marathon. I came up to 942nd. I only wanted to finish, which is what most of the athletes want to do.
Yeah.
They just want to finish. So they've done the Ironman.
So, okay, so the cycling is an embarrassment.
It was, because I lost so many places.
I see. Not as a sport, an embarrassment, but rather for you, from your experience.
A little Australian girl came up alongside of me and says, "You all right, sir?" I said, "Get on your way."
How old were you when you did the Ironman?
I was 45.
Wow.
Yeah. I did the Ironman 1 year and swam the English Channel the next. I became the first person to have done those 2 events.
And what's the distance of the English Channel?
21 miles, closest point to closest point, if you're lucky.
And rough waters.
Yeah, rough waters. Cold waters, 60, 62 degrees. I did it in 12 hours, 58 minutes, and 14 hours, 10 minutes.
So something like that, swimming the English Channel.
Right.
Is it you doing it with a team of people?
No, you're by yourself with an escort boat alongside of you. On board will be, of course, the pilot of the boat, and he has to have a backup. Legally, there's safety rules. Then there's the observer from the Channel Swimming Association, make sure there's no cheating, that you're not wearing a wetsuit, that your bathing suit doesn't go below the crotch or above the umbilicus.
So there are standards and certain rules to stick to tick the box to say you've done it.
That's right, and you can touch the boat to push off it, but you can't hang on to the boat. And when they feed you, perhaps, in my case, I like to be fed every hour, that food's in a bucket on the end of a pole. And you can't hang on to that. You can reach into it and take out what you want, because you know what you've already decided. You know what's there. You've been practicing.
So what do you eat on swimming the English Channel, cold waters, it's raining?
Bananas and flat Coke. I pour the Coke out about 2 days in advance, so it's totally flat. And so there's no fizziness to it that would upset me. And so what you get is the sugar, the caffeine, and the moisture.
So it's flat Coca-Cola.
Flat for Coca-Cola.
All right.
So, but that's what I swam the channel on.
Yeah. I'm assuming it was delicious.
No, it's all right.
Yeah. So no wetsuit.
No wetsuit.
So it's just skin. You're in the free.
Well, you're allowed to put a bit of grease on, about the size of a good coffee mug full, right? Yeah. And you tend to put that in areas like, forgive me, your private parts, or where there's friction.
Yeah.
So, like you might put it where your chin might strike your shoulder. You might put some there. Ladies usually take off they swim with a two-piece bathing suit, and they'll take off their top piece and swim without it. After all, they're going to be arriving in France, and most of the people on the beach ladies on the beach don't have a top on. But you think about it.
Is it only done is it done one way from England to France?
Yes, you can't do it the other way. The French won't allow you to go over there and start there. The French are difficult, traditionally.
Allegedly.
Allegedly. We British think they're difficult. Anyhow, no, so you start in England, of course, and then you're allowed to arrive in France, but most swimmers don't get across, you see, so that cuts down the traffic in France. But if you do get across, then you've got to be off the beach within 3 minutes, back to your dinghy. The boat would have stopped, the dinghy would have gone in, escorted you in, you swim back out to the dinghy takes you to the boat, and you're off back to England again. But going back to the ladies for a moment,
yes.
Your arm's going to come over some 33,000 times in a swim across the channel. And if you've got a strap coming across the shoulder, you're going to have friction problems there. So that's why they'll take the top piece off, most ladies will.
And any exposure to animals, sharks?
Well, jellyfish.
Jellyfish.
I was hospitalized after one of my swims. I swallowed part of a jellyfish. You could see the leg mark across my face and it ended in my mouth. I must have inhaled it. It hit the uvula and it paralyzed the uvula, and I was choking. So I had to keep my head way extended back so the uvula would stay back and I could breathe. They sent out a rescue boat, took me off my boat, took me to the hospital. I spent 2 or 3 days in the British hospital.
So what are your thoughts then? You're sitting there in the hospital for a couple of days. You've endured this terrible thing. I'm assuming while you're doing that, you have a lot of things going on, in parallel, maybe, more important things, family, kids, businesses. And you're sitting there in hospital after you swallowed a part of a
Well, it was one of my proudest moments. What had actually happened is that as we approached France, the boat grounded out on a sandbar. And it was my boat. I'd sailed it from America to England with my wife. And my wife was helming the boat across the channel. She was very good at the helm. And so there's the pilot alongside and the official people. But we'd used our own boat. It's a rare thing, but I was connected to the association. I'm now vice president of the Channel Swimming Association currently. Anyhow, we hit a sandbar and the boat got stuck. And the next thing I know is my dinghy's alongside of me, and the referee is saying, "You've got to get out, your boat is stuck." And the tide's going out, and that's really bad for a boat because the tide's going out, and it's a yacht, you're going to go down, and the boat's going to sink. It may not float up again as the tide comes in. So I got back to the boat, climbed up on board, got the boat off, and we then got free of this and started sailing back to England. But here's the point. I hadn't finished the swim. The rules say you must exit the water on your own account to dry land. And I was about 400 yards, 300 yards at the closest off France when that happened. So now on the way back, I lose my uvula, I can't breathe, I'm taken off, put in hospital, and the secretary of the association comes around, and she says to me, "You were granted the swim by your observer because of the circumstances, but we can't grant that. We're going to deny the swim, but we're going to ask you to appeal to the whole board." And I, too, hadn't walked up that beach. I, too, wanted to walk up that beach, and I knew I hadn't completed that swim. So I grabbed the pad that I had, because I couldn't speak, and I wrote, "No appeal. We'll try again in 3 weeks." And that's what I did. In 3 weeks' time, I succeeded. I walked up that beach. So the question is, have I swum the channel once or twice? All my colleagues say you've done it twice, but the record book, to be honest, only shows me there as having done it once. But that was a proud moment because I respect rules. I may not agree with them, and I have fought to change many a rule. But when a rule is in place, those are the rules you play by, and I do that. So for years I was in charge of the rules in terms of liaison between the swimmers and the pilot boats. I was a safety officer and things like that.
How long is such a swim? How long did it take
21
you?
miles, and I did in 12 hours, 58 minutes, and 14 hours, 10. It'll ruin your whole day, frankly.
I'm sure it sounds like it.
But it's a great achievement.
Yeah.
I mean, we've got, I think, what was it last year? 2,000 people climbed Everest last year. And I think about 160 got across the channel on average here. Getting up Everest today, if you're a good climber, they're going to get you up there. You don't have to be a great climber, but you've got to be a pretty good swimmer to swim the English Channel. It's tough. And none of the modern technologies are helping you. I mean, nothing's helping you. A better diet maybe, but not better swimming suits, not better anything. Better goggles, yes, than the first guy. But nothing really that makes it easier. It can be tough.
So is swimming maybe the endurance sport that you're best at?
Yes, but it's not the one I like the most, you see.
So which one is the one?
I think one of the secrets in life is to be good at something that you enjoy. I never really enjoyed swimming. I found it boring. Going up and down a swimming pool with a green line underneath hour after hour. I mean, just to get into a swimming team. I like the swimming team, the trip to Australia, right? And I wanted to get across the channel. I was inspired to do that. But the training of 3 and 4 hours a day, it would drive someone with average intelligence nuts. So that's not so good. Sailing is the sport that I enjoy most. And I've sailed around the world and compete in a number of races. I enjoy it. Am I good at it? Well, I think I'm good enough. I've won a few races, as I mentioned. I'm good in bad weather, and I really enjoy being out there on the water.
And you still do it?
My sailboat's up for sale now. I'm 86 years of age, and I've noticed over the last 3 years I don't have the upper body strength I used to have. And so in rough weather, if you go forward on your boat, you're wearing a safety harness, and you're harnessed onto a line. But you could get swept overboard. It's happened. I've seen it happen. Never happened to me, but it's there. And then you've got to pull yourself back up. I don't believe I could do that today. And I've also noticed my balance is not so good. And so I decided that in the interest of safety and having a good life and wanting to continue it, I've done all the risks in sailing I needed to do. I've done what I wanted to do. Got some 200,000 miles on my belt. I've sailed around the world. Sailed across the North Atlantic a half a dozen times. I've won some races out of 212 boats from Spain to St. Lucia. I came in first. I don't have anything else to prove in sailing.
Was that a sad moment, the last sail you've been on?
I actually I finished it with a bottle of champagne because I kind of realized it was. I was sailing up to, from Florida here, I was sailing up to Newport, Rhode Island to take part in a solo race from Newport down to Bermuda. And we ran into a really bad storm. I had two people on board with me. It was really rough. I was hanging on to a fiddle. That's something you hang on to. And we hit a wave, and the fiddle came away, and I was thrown across the cabin. I split the top of my my head, not bones, just the skin. It bled profusely for a while. And I got up there, and I just realized, the boat couldn't take part in the race because the engine had broken down pretty well. We need to replace it. So I said, the boat's for sale.
And you popped and opened a bottle of champagne?
I did.
That day?
I did, with my teammates. I said, let's celebrate our arrival and celebrate the end of a successful sailing career.
Fantastic. And you've had a few other excursions like that. I read about the cycling from one coast to the other.
Oh, yes.
In the United States?
Well, I'm a member of the Physical Therapy Foundation for research. And I've done a few things to try and raise money for it. And one of them was to bike from San Diego, our campus there, the University of St. Augustine in San Diego, to the University of St. Augustine campus here. It's 3,000 miles, and I decided I could do that in 30 days. So that was 97 miles a day, actually, to be more precise, that we averaged. And two of us did it. So other people joined us at certain points along the way. Didn't raise a lot of money, but it raised awareness. A lot of therapists knew we were doing it, and more learned today. Because the Foundation for Physical Therapy Research is what has helped elevate and improve the value of physical therapy in this world today, and that helps with reimbursement.
And was that a proud moment, finishing that? Was it a 30-day cycle?
Again, a good excuse for a bottle of champagne.
Yeah. And then one more I'll throw at you also that's super interesting. Motorcycling.
Ah, yes.
Also from Alaska to Florida, or Florida to Alaska?
Prudhoe Bay, Alaska to Key West, Florida.
It's a long way.
8,000 kilometers, 5,000 something miles, 5,400 miles, I think. And I did that in under 10 days.
Wow.
So that was like 500 miles a day on a motorbike. That's kind of uncomfortable. And it was very uncomfortable. I was quite often standing up on the bike with wiggling my rear end. In the past, I've seen a motorcyclist do that, and I thought, what the hell are they doing? They're showing off. No, they're in pain. And they have to take the pressure off their buttocks.
And so you spent, like, even just those, adventures you've been on.
Right.
It's a lot of time alone.
Yeah.
Solitude, thought.
Yeah.
Is that something you value, connect to?
Emerson wrote, "Pity the man who is alone, but pity still more the man who cannot be alone." My time alone, whether it's a long distance drive or on a motorbike or out there sailing, because I'm a solo sailor. I've tried to go around the world solo. I tried 5 times. I got as far as South Africa 3 times.
Starting from?
Starting from St. Augustine. It's a lot of time for thinking and reflecting, and I think some of the most valuable time. I think a lot of us are so hectic in our business lives, and then on top of that our family and social lives, we don't get time by ourselves to think and reflect. And I've done a lot of that over the years, and I find I get great energy from that. And it's not time wasted, it's time more efficient. And when I come back from doing something of those natures, I've usually got a yellow pad or 2 in front of me full of notes and things I want to get started on. In fact, the staff say, "Oh, here he comes. We're going to be busy for the next week or 2.
So yeah, you've only seen it as a moments of value to you.
Yeah.
And it's something that has become easier, or is it always some sort of a challenge to be alone while so many things are going on around you? Because again, like, even if you are comfortable with being alone for 30 days,
right,
still the businesses, the staff, the family, it's all going on every day, every second around you. And nowadays, it's rare you even find someone that can go on a 20-minute run
Right.
without plugging in a podcast or
Right.
plugging in music for some sort of entertainment distraction.
Well, back when I initially did these things, there was no communication once you left shore. There was no satellite phone, for instance. There was no cell phone when you got within shoreline. There was nothing. So you were alone. Yes, you were. When I went overseas to study, I mean, I wrote letters home, but nobody used a telephone in those days. It was just too expensive and difficult to make the connection, you know. So, no, I got used to that.
Is that something, though, like you have kids?
Yes.
Is that something that you have to try and, in a way, show the value of? Because it's not intuitive to many people. Because it's easy for it to seem like time wasted.
I got 3 sons, grandchildren too, but 3 sons. They're totally different, one from the other. One has sailed around the world solo, and in a 5-stop event, but it was an organized event. He succeeded at that. The others are not interested in sailing. They've been into sports and they're academics, and they're more regular people, but they're fine. My second son is a master of wine and senior sommelier, and we have in New Zealand 8 wineries, eight I should say vineyards, and 2 wineries.
Do you drink?
Oh yes, of course. I probably drink a bottle of wine a day, which is considered heavy drinking. But then, you know, I'm 86, right? And my doctor, he resigned, he retired about 2 years ago. And he said his last words to me were, have you got any concerns? I said, yes, I think I'm drinking too much. And he turned around, he looked at his screen, and he brought up my liver numbers and everything else. And he turned around, brought down his glasses and looked at me and said, you know, your numbers are good. I wouldn't change anything. And I said, I'm going to miss you. Because the first time the new doctor came in, she said, you're drinking awfully much. I just laughed at her and said, yes, but I'm 86. And she said, yes, you're the healthiest 86-year-old I've got on my patient list.
So what do you think? Is there a secret?
Oh, no.
Because again, you look great for an 86-year-old, really great, and you've done all these things that one would think that you'd show up here in the podcast studio all beaten up by life, but you look the opposite, and you radiate the opposite.
I did the most in my midlife, in my 40s. In my 40s is when I did the Ironman and swam the Channel, and did distance sailing and things like that. Because between 20 and 40, I was so much into my career. I was so much into pursuing everything I could and learning everything I could about anatomy, biomechanics. I was so involved in the profession. I was on the road teaching seminars. I was building practices, here in St. Augustine. And as you know, it led to the creation of a university with 4 campuses nationwide. University of St. Augustine, largest physical therapy school and occupational therapy school in the United States. That took a lot of time and work, but that, I'm getting ahead of myself. That was a little bit later on. But what went into building me to be able to do these things was a dedication to my profession, to helping the patient, to health sciences. So most of what I did, with the exception of one thing, was at my middle age. However, go back to 1960. In 1960, I drove a car from England out to India and then raced back. There was a record for the 12,600 miles from Calcutta to London.
Okay, I'll have you repeat that again, because if someone's listening, that can be brushed off as a quick little easy trip.
Okay.
So from England to India.
Yeah, you couldn't do it today because of all the things that are going on in Iran and Afghanistan, and even the Indio-Pakistan border is not always crossable.
Yeah.
But back then, the world in 1960 was a relative peace. The Second World War had ended, nuclear powers were in place, and the world didn't know that a small country could fight a big country, as we would later to learn in Vietnam and other kinds of events. And we now know the Houthis and Saudi Arabia can create a lot of problems. But that wasn't known then. Everyone behaved. And so it was possible to drive from London to Calcutta. And someone did that. He was a travel agent. And it's 8,860 miles. He did it in 12 and a half days. And given that I knew I was an endurance person, and I'd been a rally driver in New Zealand during my college days, I managed to get a scholarship from Volkswagen I learned how to say that, Volkswagen. And I got 23 other sponsors. And I put together a team of mechanic and journalist and myself. And we drove out to India, and then we raced back. Halfway mark, we were in Iran. We were a day ahead of the record. Only one driver allowed, by the way, and that was me. The other two guys alternated sleeping with keeping me navigated, because we'd navigated on the way out. The engine seized.
Three of you in the car.
Yeah, 3 of us in the car, and the engine seized. One slept. We had a bed from the dashboard to the back seat, and just 2 seats, the driver's seat and the seat behind. And we did our cooking underneath. And it was a Volkswagen Beetle. And we had a big rubber bladder in front full of gasoline. Someone said once, we've had a bad crash, what would happen to all that gasoline? I said, we wouldn't know. We'd be gone.
And the engine did fail?
The engine failed. A screw came out of the sump plate, and before we knew it, the engine had drained oil, and that seized. And the time we got the engine fixed, in 5 days, the record was lost.
But you completed the drive?
I completed the drive, yes.
And what was the race back, you said?
Yeah, it was the race was on the way back from Calcutta to London. And at the halfway mark, that's when it failed. But yeah,
fantastic.
But I've had more failures than successes, and I think that's important to know. I mean, okay, I swam the English Channel twice, but I've failed 7 times. I've sailed around the world once, but I've tried to do it 5 times solo, and I've failed each time. So failure has never been a problem to me. I'm very good at it. But what I'm good at is not letting it put me down. Because if you have a fear of failure, you won't try anything in life. And you've got to put that fear away, because each time you may learn. You may never succeed, but look at the excitement you get compared with the average person leading a mediocre life. I never wanted to be mediocre. Can't stand that. I wanted to succeed at whatever I did. And I said, I'm not terribly competitive. I want to be successful there, because that's what gives me enjoyment. If I can achieve economic security and then I can do good things, I'm going to be happy in my life.
And is that something that also is reflected in your business life?
Yes.
Because there's a lot of, again, many people since the 60s have started physical therapy clinics and educational programs,
Right.
etc.
Right.
So did you fail? Did you face a lot of failures?
No, not in that so much, no. When I came to America in 1966, it was my second time here, but I came now, and I've stayed, as you can say. There was no one teaching continuing professional education courses at all. State chapters had business meetings. They didn't have speakers. I might have a doctor speaking, but there was nothing instructional. There was nothing very much. I started it and in manual and manipulative therapy, and a gentleman called Ron Payton, who founded the sports medicine section of the American Physical Therapy Association, he ran a great program called Dogwood Seminars in Atlanta. He and I teamed up. I learned from him, he learned from me, and we were the first 2 teaching graduate education. There were no graduate degrees in physical therapy, and the first one was a master's in education I think at universities like Emory and others. I started a master's degree in orthopedic physical therapy, specializing in that. That was at the graduate level. I started that in Atlanta and brought it down here. That got licensed, accredited, and eventually enabled me to start a full physical therapy school, and then occupational therapy and so on.
And now, where do you have campuses? You said in Miami, San Diego.
Austin, Texas, and Dallas. But there were 4 when I sold the university. Now there's 5 campuses.
Fantastic. And you said it's all strictly physical therapy and occupational therapy.
Now the new owners have added nursing and physician assistant program. I believe it's about to start. They've got a dietitian program in one of the schools. Yeah. They're gradually growing the university.
And so, the physical therapy profession now in the United States, let's keep it there for a second, then you're saying it has grown in value also as a profession since the 1960s and turned into what it is today, because even today in most states, or not most states, but some states, you even have to complete a doctoral program to practice as a physical therapist.
They're all doctoral now.
So they're all doctoral?
Yes, they are. They used to be a diploma, and then it moved to a bachelor's, then it moved to a master's, and then it moved to a doctorate. Basically, I think moving to the doctorate, and I argued very much against it at the time, that was being talked about. Because I thought, once we get a doctoral degree, the average therapist will think that that's it. They're a doctor. Okay? All right. But if you graduate with a bachelor's, there's always a master's that would encourage you to go back to school to learn more. If you got a master's, there's maybe a doctor of health science. But once you put a DPT there, I think you'll stunt the growth of physical therapy. And I think to a large extent that has happened. I don't know that we needed a doctorate. I would have put that at the specialty level if we had it. So basically, I think that was a mistake. But there is a thing called degree inflation. And I mean, even the quality of a PhD today is sometimes being watered down and being offered too easily.
Yeah, which we see in other professions all over the place.
I think so, yes.
Yep.
And it's all part of, we must all succeed. No, we must not all succeed. Not everyone can win the running race. Not everyone can be top of the class. But someone deserves to be. And I think we should keep to that. If we take away the spirit of achievement and try and make it easy for everyone to get the degree or whatever, and we don't distinguish excellence from ordinary, I think we're going to lose a quality that's not good in our lives, it's not good for the economy, it's not good for America. And if it's not good for America, it's not good for the free world.
So when you started St. Augustine School of Physical Therapy, were you emphasizing manipulative and manual therapy work and techniques for physical therapists?
That's a good question. There are already 212 schools in the country. And I made it clear to the people who were backing me that there was no need for a 213th school. Now, I think we probably have 250 now. But there was no need for another school like the existing schools. Leave that to the established universities. I said, unless we can really make a difference, unless we can define what it is we're going to do to contribute to the profession that others might follow, we have no business getting into education, not as a private school. And that's what ours is, a private for-profit school. And we found it. What we did is we said in our advertising that we would educate our therapists so that they would be eligible for sitting the state boards. But our emphasis would be on orthopedics, including manual and manipulative therapy. And we had a good reputation around the country by teaching continuing education. When our graduates of those continuing ed courses saw that, they recommended our school to people because they knew our quality and they knew that we meant what we were going to do. So we did very well. We had 3 or 4 applicants to every slot in our first year. So it wasn't too long before we took 3 classes a year. And it wasn't too long before we opened in San Diego. We were invited to come out there by the people in the Southern California chapter of physical therapy. They wanted a school there. So, we made a difference.
So was that your distinguishing factor? Is slowly focusing on manual therapy?
Yes.
Because we're 60 years later, almost 50 years, 40, 50 years. Today, again, it's as a general, stereotype, it still seems like physical therapists, generalizing, shy away from manual therapy.
Well, yes, there's something that's happening that doesn't make me particularly happy. When we first started teaching manual manipulative therapy on a continuing educational program, and then at the master's level in one school in Atlanta, Georgia, there was an excitement about it because it was new to physical therapy. Physical therapists weren't doing it. And the physical therapy profession as a whole, and the educators as a whole, they were opposed to it. It was too close to chiropractic. Which, as you know, at one time had some theories about vertebrae being out of alignment causing all human disease, and all you have to do is to put the vertebrae back into place. Well, most of them no longer subscribe to that. But that created resentment to the medical profession. Our schools are controlled by medicine in those days, so manipulation was not something we did. We started at the very beginning. Mary McMillan, the founder of physical therapy, defined manipulation as part of our practice. But then the rise of chiropractic, the medical wars with chiropractic meant that it was taken out of our domain. So my role was bringing it back into physical therapy. And others, of course, helped with that. So there was an excitement. But eventually, We won the profession over. We showed that it was effective. The researchers showed it. So now it's mandated that it must be taught to all physical therapists in their training. So who's teaching this? Well, these are academics, by and large, who lack everyday hands-on clinical experience. They are not skilled. There'll be the occasional one, but most of them are not skilled, and they're having to teach manual and manipulative therapy, whereas they'd rather teach exercise science. And so they're dumbing it down so it's not important and if they do teach it, they're not inspiring. They're not able to show the skill or the examination that goes into the patient before you do the skill. They're not able to speak about the rationale with the depth that's needed to instill in the student that this is a very worthwhile practice, but it's going to take a lot of work on your part to be good at it, become a master clinician. So yes, it's getting a little bit of a bad rap, but things come and go. I think that tide will turn again, but it might take some time.
Also, it seems that everyone, and I am on purpose generalizing, or because everyone has pain, everyone has things going on with them, and I don't think most are also robust as you. So as people get older, they are in dire need of physical therapy, of some sort of therapy to their body to literally keep them going on a daily basis and able to, do the regular everyday things, the picking up your grandson and going on walks. People need help,
Right.
and it sometimes seems like the patient is not the starting point when teaching these things, because like you mentioned about the people teaching these different things in the classroom maybe lack that everyday out on the field experience.
Right.
They're also missing out on again, I'm assuming because you've touched a lot more bodies than I have, but the nuance of the human body as well. Again, if I come to you with hip pain or knee pain, and someone else comes, we might have the same condition, but it might not feel the exact same way.
Well, you mentioned pain. Pain is what brings most patients to us. But I don't think we should be treating the pain. Our emphasis should be on determining the cause and treating the cause of pain. And so I've focused on that. Whereas many people focus on treating the pain. And that's what heat and massage was generations ago. Today it might be exercise and things of that nature, just to treat the pain. So what we're missing, I think, in many cases, is that thorough initial examination of the patient. Their posture, their body movements, their passive movements, the end feels at the end of joint range, checking for a component and joint play motions, and treating the impairment. And that's the best thing you can do. That usually will relieve the pain. If you just focus on the pain, you may relieve the pain. But if you haven't corrected the impairment, that pain will return. It'll return on the older patient. It'll be more chronic than before. And whatever you did last time that helped might be less able to help this time. And you still left them with the impairment. So I believe in treating the impairment, and the pain usually takes care of itself. And if I've treated the impairment and they've still got their pain, then I'll do things to help them comfort their pain. But that's not what I treat. It's the cause of the pain I emphasized.
And the customer, the patient, the person coming in with the pain, is that what they want to hear?
I explain it to them. But,
because you need someone to tango with you.
The most important thing is you develop a clinical presence. So you go out to the reception area. It's not a waiting room. It's a reception. You say, Mr. Jones. He says, yes. You stand up, offer my hand, make eye contact. It's not just a rough handshake. It's a feeling handshake. Come with me. First thing I say to him is, now, tell me in your words, how do you see your problem? And what is it you would like me to do? So we begin that discussion. Within a minute, they've got off their chest what they're thinking about, they've been wanting to tell you, because they know they're coming, they're going to have to say something. So they've said it. And I say, good. I've now got a set number of questions I need to ask you to fill in the things to help make sense to me. It's a structured interview, Mr. Jones. But at the end of this, you'll have an opportunity to talk about and agree with me on the treatment that we're going to do with you. So away we go. And it's a half-hour process, so usually it can take longer even to examine that patient completely. And when I say to them, now I've identified these problems, these I believe are the cause of your pain. These I'm going to treat. That will take care of your pain, I believe. That's the best chance that I can give you at this time. Are you understanding that? Yes, okay. Then away we go. And when he comes back the next day, I don't ask him how he feels. I say, come with me, Mr. Jones, and I'll let you know how you're doing. In other words, I'll check those impairments and see if I've improved them. Or I might have done that at the end of the treatment session, but now it's more important the next day to see if they're sustained. And so I build on that. Now, that said, he's already answered a pain questionnaire, which was about 100 words describing various pains in various categories. He's done all that. He's been asked about his pain in the examination, so he knows that the pain is not being ignored. But I'm shifting him to understanding that it's the impairments I'm treating, and the treatment is what I'm giving him, plus the instructions I give to him for him to carry out in between times. That will be posture exercises, and I call them supportive treatments.
Is all this part of education?
It's part of the philosophy that we taught.
Because, again, like establishing that dynamics with the patient seems crucial.
Oh, yes.
To the therapeutic process, because the patient doesn't know how to act
right
in those situations.
Well, there was I forget who it was that came out with the concept of the three-legged stool, that when you're deciding what to do with your patient, you've got three legs on this stool. The first is research. What does the current research say? The second is, what is the expertise of the clinician? What is it that clinician's able to do? And the third is the patient's preferences. So I'm very much into being the skilled clinician who looks at the research and says, okay, as long as I don't go against the research, I'll be fine. I know that most research that's considered valid today, 10 years from now, will not be. So I'm skeptical of research. I know it looks at simple questions, not the big questions. It has a hard time really studying clinical effectiveness sometimes. So I'm comfortable with what I know. I'm not going against the research. I'm probably not going to use too much of it, though. I'm going to talk with the patient about what I found and what I want to do and what their role is. After all, it's their condition, and if they don't cooperate, it's going to make my job a little bit harder. We need to win their support. But you do that by your professionalism. But you do that by your initial greeting of that patient in the reception area and the way you treat them through the examination process. You win them over to your side. And in the end, they want to get better to please you, the therapist. Because a lot of what we do is placebo. We know that. We know that whether it's a medication, whether it's a surgery or a sham surgery, it's 30% maybe. Could be less, could be more. Is placebo. Patients feeling that this is going to help. And if they feel you can help them and that they know they're in the best place, that's the most likelihood of having a successful outcome.
When you say something like a lot of the research that we currently know in 10 years won't be as valid, it's a bit discouraging and demoralizing, especially I'm thinking if I'm sitting here as a young physical therapist, I'll be thinking to myself, crap, like,
no,
what am I supposed to do?
No, we're improving on the research. And so what we accept today as being good research will be 10 years from now, it won't be quite so good. We will have shown that something else is a little different. Look, a few years ago, clinical prediction rules were the way to go. And I was so much against them. What they did is they took a set of symptoms and signs and they did a treatment. And if treatment worked, then that was a new way to treat that. Well, they became the rage because it was now easy for any therapist to ask a half a dozen questions, conduct a couple of tests, and know precisely what they need to do to treat the patient. And it worked. But it didn't work extremely well, but it worked better than not having that. So suddenly we had lots of these clinical prediction rules. You don't have them today. They've been proven not to be reliable, not to be repetitive, and one thing and another. So that was a piece of research that's gone by the way totally. No, most research will not be thrown away totally.
So
most of it's valid. But one of our problems is there's a lot of good research that was done 20 years ago and is still valuable today. But because it hasn't been repeated recently, it's not considered valid today in practice by educators. And sometimes you see CAPTE, our Commission Accreditation of Physical Therapy Education, requiring the curriculum quotes references, I think, something like in the last 5 years. And they see references from 10 years, they're not so pleased with that. That's wrong. So while I say that, yes, what we're doing today is supported by research will be different 10 years from now, some of that will remain because it's good, but not most of it.
What are some of the big questions that you would like the research to emphasize on? And you mentioned you were very involved in raising money for research in physical therapy.
My wife and I are the largest donors to the Physical Therapy Foundation for Physical Therapy Research. And we do the same in New Zealand, and we do the same through the Academy of American Academy of Orthopedic Manipulative Physical Therapy. I believe in research. It's important that we can do the research that proves our effectiveness. That's important for reimbursement, because today physical therapists are not as well paid as they used to be. And that's an act of a number of things, the economy, Medicare, all those kinds of things, which I'm not current with, so I really can't give you the details. But I know that in order to sustain where we are and to have the grounds for improving it, we must show our effectiveness, and that's because of research that we will do that.
But is it like a big question that you would love research better, honed in on, that you think can be relevant?
No, I think we're basically in the right direction. The APTA and the Foundation, American Physical Therapy Association, and the Foundation for Physical Therapy Research, we work cooperatively on trying to define what projects are important, what areas should be researched across the broad spectrum of physical therapy. Those monies are well spent for the most part. We're getting better at spending that money appropriately to get the kind of results that we're looking for.
Where do you think different, parts, other modalities, maybe some things that might be outside the scope of practice for physical therapists, but the basis of the understanding of them, if they can be of value to physical therapists, and like stuff like, we're sitting here in a next door. There's a acupuncture, a traditional Chinese medicine clinic. So where does that come into play at all?
Sure, but it depends on what your level of expertise is. I mean, I'm an orthopedic physical therapist with an emphasis in manual and manipulative therapy. I seem to have got good results with what I was doing without having to resort to some of these modalities. If I wasn't quite so good, I might find I needed to lean more on acupuncture or dry needling. But I haven't. In fact, I used to be, and if I were in practice today, I think I still would be, a user of hot packs and massage, which there's very little research that supports it. And there's very few people that think it's of value, and you may not even be able to charge much for it today. But why? Why do I think that's important? Well, when the patient on their second or third visit and so on comes in from the reception area and lies down on the treatment table, I like to put a hot pack on them for 10 minutes on the area that I'm going to be working on. It's an opportunity for them to rest and relax from whatever they've been doing, rushing to get to you on time. They lie there. It warms up the muscles. If it's a lumbar spine, for instance, I will then remove the hot pack. I'll do some massage. I'm helping to give nutrition to the muscles, because no matter what your back pain problem is, the disc, the facet, the sacroiliac, a ligament strain, the muscles are going to be involved. They always react. Their tone will change. And I'd like to relax them. And I'd like to bring them nutrition. Then if I'm going to do a manipulation to a stiff segment or whatever, I'm then going to be able to do it with a lot less force, more specificity, and achieve my end results because of that. It only takes a minute to manipulate the patient, but the preparation leading up to it, I think, is important. It's being neglected by a lot of people today because of reimbursement and current customs.
So what is the problem with reimbursement now? And is it specific to...
You're asking the wrong person, although I was discussing it earlier today with a
is it
colleague of
specific
mine.
to physical therapists, though? Or?
Well, you know, the reimbursement for physical therapy, as I understand it, under Medicare and other insurance companies and workers' compensation tend to follow Medicare, is that we are restricted in the number of patients we can treat a day, which seems to make no sense at all to me. And we're restricted in the reimbursement, and it's not going up with the cost of living. So a physical therapist back in 1998, for instance, could be making 50, 60,000. Well, today I don't know exactly what that translates to, but I think it's about 120, 130,000. Most therapists are still under 100,000 in their earnings. So the reimbursement for therapists hasn't kept pace with the cost of living. Additionally, because we added the DPT, the cost of education has gone up because of the extra time required to get the DPT. And as you know, universities have raised tuition rates faster than the rate of inflation. So today the therapists, with their debts and one thing and another, they're in a problem because their reimbursement isn't that great. It's not as an attractive a profession as it used to be. You don't go into physical therapy to make a fortune. You go in because you're motivated to want to help patients. You like caring for people. You are a physical person. You're not into the psychology, you're not into medicine, you're into the physical aspects of life. And you see that opportunity to be involved in that in the profession of physical therapy, and it brings you great joy. The problem is if you're not being well paid, it's difficult to support a family and have economic satisfaction there. That's not as easy as it used to be.
Continued education or continued professional education development for physical therapists. Mm-hmm. Now with the changes of education and, becoming from a diploma program now all the way to a doctoral program, mm-hmm. where would you recommend or where would you like to see the continued education part come in for physical therapists after they've completed this, I think, 6 years of study now?
Right. Well, most states require it to maintain your license, mm-hmm. but it's a mediocre requirement. It's a minimal requirement, and it can be gained in a number of ways, such as online. If you really want to, and you should, after you graduate, I think a new graduate should think about getting experience. I know they're interested in getting a high-paid job to help pay back their debts, and they certainly have them. But the more important thing is to work in a situation that gives you a broad-based experience and where you've got some mentoring, some people who will care for you and direct you and help you in becoming professional. Because the license you got is for you're a safe novice, and you have to realize you're a novice when you graduate. The learning really now begins. And so getting a good mentor into a good clinical situation is important. The next step is a residency or a fellowship. And that's where, again, more mentoring takes place. So I really recommend those approaches. We have lots of residencies and fellowships growing within the profession. Those residencies and fellowships are often supported by continuing professional education seminars. But seminars like that now are not as popular as they were. And this because I think there's a change in the mentality of the person who becomes a physical therapist today, or perhaps in any profession. I'm older generation, and I know I can't speak without somewhat sounding critical of the current generation. That was true of my grandparents talking of my generation. I think that's the way it always has been. We don't believe people today are necessarily having the values of the people of yesterday, and they're losing some of these values. So yesterday, 10, 20 years ago, when you got out of school, many of them, people were committed to their profession. It was the first thing. Family was second. pleasure and other activities was third. Today, many people graduate from college hoping they will get a job so they can earn some money so they can have their lifestyle. They're not as committed to continuing professional excellence as they used to be. 10 years ago, 15, 20 years ago, there was no problem to put on a 2-week-long seminar. The foundational course I taught in manual and manipulative therapy was called S1, the spine, 2 weeks long. No one will come to a 2-week-long seminar today. They don't have time. They don't wish to make that kind of financial commitment to go fly, stay in a hotel, pay the tuition, and invest in a 2-week thing. They want it now in 3 days, the same material. They'll get some of that online, but the hands-on portion is very brief. They don't invest in themselves. They're not as willing to do that as a previous generation. It may change. I hope it sincerely does, because in the interest of our patient, we need to be dedicated to what it is we do. We need to know that when we graduate, we're a safe novice, but life is beginning. We've got more work to do to become an expert clinician. And that takes dedication, takes more learning, feedback from treating a patient to learning to feedback to treating a patient. You just don't get that when you graduate from university. That's the beginning.
You mentioned that the role placebo plays in all treatments, and every time we administer something to a patient, and I believe also I read that neuroanatomy was your field of
my PhD was in neuroanatomy. Yeah.
Which is the anatomy of the brain?
No, I actually studied the innervation of structures in the lumbar spine. I used 32 fresh adult human cadavers, and using very good photography and video equipment and dissecting under microscope and so on like that, I was able to describe better than had been described the nerves that supplied the disc, the facet joints, and the sacroiliac joints. So that was of use mainly to the medical profession more than it was use to our profession, but that so happens sometimes. But it helped me understand and helped my clinical practice in some ways.
So that falls under the umbrella of neuroanatomy.
Yes, it does. Yeah.
And because again, there's always things coming out and books written and research papers about the connection, the spine and the brain.
Right.
And even going through, a spinal injury, or even, stimulating the spine in a certain way, like activates part of the brain and part of the body.
That's the physiology. That's not my expertise. I have an understanding of it, but I wouldn't be speaking on it.
But it's something that you've felt yourself through like exercise. Like even in the yoga world,
right.
like certain poses or certain twists,
right.
Really like do bring up something within.
Well, if you take yoga, take Tai Chi. Meditation itself, I'm sure that those things are of great value. I have not practiced them. Have I done them? Yes. Oh, yes. But I've not practiced them to any degree. My just sitting and relaxing, looking at the ocean works for me from the cockpit of my boat. I don't feel the need to do something of that nature. But I certainly applaud it. And when I ran the Atlanta Back Clinic in Atlanta, Georgia, we had 35 staff, 2 physicians, 5 psychologists, about 7 physical therapists, dietitian, pharmacologist part-time. We did teach Tai Chi, and we also taught some yoga things because we felt that was helpful to these chronic back pain patients to try and get them outside of the self, more healthy activities, but to get some control over their lives. And did it work? Maybe.
I've been saying for a while, I'm 30 now, that I want to be 75 and being able to run,
Right.
because I run, and usually people think that sounds crazy, but you're kind of evidence to
Right.
me that it is possible.
Yes, I think so.
So what would you sell? What would you tell me as a 30-year-old to keep doing or to do?
Everything in moderation. Everything in moderation, but be active, of course. Do keep your running up. Tomorrow, for instance, my wife will be running in a half marathon in Central Park, New York. She's run about 21 full marathons, and now she does half marathons. She's 70 years of age, and she still enjoys the excitement of the event and taking part. Is she good? No, not particularly, but she enjoys it. And that's the value of exercise.
And can my joints be okay?
Yes, hers are okay.
So-
She doesn't
so
have
how?
I'm the one who has a couple little joint things, and no replacements at all.
Yeah.
But she doesn't have any joint complaints at all. Not at all. And now she's more active than me.
So, although counterintuitive to many in this world and day and age, but continuous moderated activity actually strengthen your
Yeah.
joints and
Well,
not
maintains them. But when you get to
but not kill them, because a lot of people think that, okay, if you're going to run 3 times a
Right,
week for the next 20 years, that's it. By the time you're 40, your knees will need replacement.
No, that's not true. We rush to replacement too quickly these days. I'm sure because I have a slip femoral capitis in my hip and a faulty neck angle of the femur. When I last had an X-ray taken of the hip some years ago, just because we had an X-ray available in the clinic to do it, the hip didn't look too good. I'm sure today it doesn't look good at all. And if I was to go to the average orthopedic surgeon who does hips and complain of pain, they would suggest replacing it. I don't have a problem with that hip. It hurts at times, yes. But if I change my footwear or change the side I'm sleeping on that, I can manage it. So I think we too often resort to surgery today to replace joints. I think it's at an alarming level, and not enough of these patients try physiotherapy first. In New Zealand, and in England I believe too, if you're scheduled for surgery, if you want to have your hip replaced, under the national healthcare system, you have to have physical therapy first. And if it doesn't work, then it doesn't work, and so you'll then be scheduled for surgery. But you just can't get it just like that because your hip's hurting.
Do you receive any manual therapy, manipulative therapy on yourself?
I have no need for it, so I'm not receiving it. My hip complaints are pretty minimal. I find I can manage them by stretching. Now, that said, I had a bad shoulder, I'm remembering now, 2 or 3 years ago. I had a fall on my boat, and I fractured the acromion. And I wanted to start swimming again 2 or 3 years ago, and I found I really had great difficulty in bringing my arm over easily. And after a few laps of the pool, it started to hurt. So I had therapy here at the clinic at the school, and it was very successful, and I was able to start swimming again. But as I said, I find swimming boring, so I really didn't go through with it at all for very long.
My last question to you, which is one that I tackle every guest on the show with, is something that, if there is something that you've fundamentally changed your mind on over the years, could be in your profession of physical therapy, or really in any space of your experience.
I've been asked that kind of question before. The question is like, what would you do differently if you had a chance to do it again? I have great trouble with that. And I know that sounds a little bit arrogant or conceited, but I've made a lot of mistakes along the way. But I've learned from them, and I haven't repeated them. I'm not a Darwinian in that respect, So no, I don't think there's much that I've changed my mind on. If we got into personal things like religion or thoughts about diversity and things, yes, I've changed opinions there, and I've changed them politically over the years, but nothing major, and I don't think anything that would answer your question.
and in the world of physical therapy, and manual therapy, and manipulative therapy. Ever since that, that day that you cracked
Right.
the guy's back
Right.
and you were freaking out over the weekend.
Yes.
So ever since then, like it was, did that ever take you down a road that you focused maybe too much time on and then shifted to another avenue?
I don't think so. I've been very eclectic in that I have attended seminars by Mackenzie and by Mulligan, and I studied under Syriacs. I went to chiropractic and osteopathic schools. I was paid to do that by the New Zealand government. I've tried to be open to everything. I've tried to synthesize it, and I came up with a model that works for me. And over the years, as I've been teaching and learning and getting feedback and seeing the research, I've modified that model. But it's been a gradual process. It's been an active process. It hasn't changed that much. I'm just reinforced in my belief that what I thought 1965 when I wrote my book, The Spinal Lesion, much of what I wrote then was very basic, but those basics are still very much in place in my mind. Not much has changed. I think fads come and go. I think what I've been teaching is on good ground. I feel quite good about that.
Dr. Stanley Paris, thank you very, very much for being here. I really hope that practitioners in the world of physical therapy, students as well, who just started, who are close to graduating, who are maybe early on in their careers, or, deciding what route of continuing education they should take in their careers. I hope they listen to this. I hope they listen to you. Because I think it's super, super valuable, and I think your dedication to, I think, yourself has obviously paid off for you, and yeah, I find it for myself inspirational. I don't know if I'll be swimming the English Channel anytime soon, but I will be running and challenging myself,
Yes.
and also reminding myself that that solitude, that time alone, is important. And I think in the world that I growing up in, it's it's difficult to carve that time alone for yourself. So it's something that I like to see, because I told you I want to be the 86-year-old who's running. So that is my goal. So again, thank you.
And thank you. I've enjoyed this.